Thank you, Phyllis. That's very sweet. Can everybody hear me with this mic? Is that all right? It's working? Yeah, good. So today I'm going to speak a little bit about the differences in interaction between a mother and her baby when the mother is suffering from postpartum depression compared to when she's not. I'll first present a little bit about normal mother-infant interaction, and then I'm going to give you a small bit of background about perinatal depression, and finally I'm going to present a small section of the findings from my research project. Bear in mind, I'm a clinician, and this is going to be a very clinical talk. So some of the components of what we look at in a normal mother-infant interaction involve these. Gaze is the face-to-face visual contact that a mother would usually have with her baby. Sorry. We want to look for positive affect expressed, mirroring between the mother and her child, affectionate touch, and motherese. Motherese is the cooing, higher-pitched, exaggerated variation in speech that everybody falls into as soon as a baby comes into the room. It's slower, it's more repetitive. So these are components that we look for. We're interested in how the dyad, the mother-infant dyad, regulates their communication back and forth. And this is not a perfect match between mother and baby, ever. There are, in fact, what are called mismatches, where the mother misses the cue of the baby and repairs it, and the repair can occur very, very quickly, within a couple of seconds. And what are considered high-quality interactions are actually where there's a match, then a mismatch, and then a repair. And these work to improve the mother's self-esteem. So this is very much like what we talk about in psychotherapy between the therapist and the patient. I want to show you very briefly a YouTube video, just so everybody can be clear about what it looks like to have a mother interacting with her baby, and the setup that is used, where we see the face of the mother and the face of the baby simultaneously so that you can watch the way that they interact and get synchronized. I don't want to play the whole thing though, so just click when I want to start. Yeah.
Okay.
Babies this young
So if I could, how
are
can I just
extremely
advance?
responsive to
Oh, wait.
the emotions and the reactivity and the social interaction that they get from.
So
the
this
world.
is actually
This is something
a
that we
research
started studying.
experiment called the still face, which I'm not really going to be presenting, but I want you to have a look at the mother and the baby's face after they've got set up.
And the still face experiment, what the mother did was she sits down and she's playing with her baby who's about a year of age. And she gives a greeting to the baby gives a greeting back to her. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we
Okay,
ask
I'm going to escape now.
to not respond to the baby.
Just push escape.
Baby very, very quickly picks up on this. And then she uses all of.
So just to say, I wanted to show that the mother and the baby's face, as you can see them interacting, and the mother's got some of that exaggerated speech going on, and you can see the way that she's bringing her baby back to her attention. So that's what we would look at then as a normal mother-infant interaction. A few words about perinatal depression. We know that there are well-established multiple risk factors, include psychiatric, social, psychological, pregnancy-related risk factors. And when the mother is depressed, sorry, I drifted away. When the mother is depressed, her behavior with the baby is different from what we saw in the previous mother. There's a flattening of her affect. She's less active, less playful. There's less stimulation of the baby, less touch, less affirming, less affectively attuned. All of this sort of goes along with what we would expect from a relatively flat, depressed mother. But you can also see some intrusiveness, some negativity in the mother, and that can be negating of the baby's experience, or it can be literally physical intrusiveness. So these two characteristics, the flat withdrawal and then the intrusive negative, are things that we see in a depressed mother. The effect of this on the baby has been most studied in what are called high-risk dyads, where there's simultaneous postnatal depression and social adversity in the mothers, single mothers, lower socioeconomic status. And as I've said, the maternal insensitivity can be one of these two types, the intrusive and hostile, or the withdrawn and disengaged. Subsequent studies have been done with purely clinical samples, meaning clinically depressed women, that have tried to look at what is the effect of the depression isolated from the social adversity, and they show similar but less severe impairment in the interaction. So then when we look at the baby who's interacting with a depressed mother, we see that the baby has increased withdrawal and avoidance, and avoids eye contact from the mother, and has a lower level of expression of positive affect. And the question is this the child's attempt to protect herself from the intrusive or hostile or avoidant mother, or is the baby imitating the mother's behavior? We know that maternal cognitions play a mediating role in this, and some depressed mothers tend to interpret the baby's avoidance of eye contact negatively. My baby doesn't love me. My baby's not looking at me. And then depressed mothers also perceive their baby's behavior more negatively, and this leads them to have a negative self-evaluation. So some questions to be answered about this is there a vulnerable period for exposure of the baby postnatally to the mother's depression? Or is it the length of exposure that's important? For example, if you have a mother coming in with postpartum depression and you treat her rapidly, are you able to protect the baby? These are some of the questions that are being looked at in the research. Lynn Murray, who has done a number of studies with clinical samples, did she had a large study ongoing, but a small subsample. She had 29 mothers with postpartum depression and 20 mothers from a control group. And she found that even when the mother's interaction was non-responsive and non-sensitive, the infant behavior at 2 months was not impaired, which is fairly hopeful. Longer-term impact on the mother-child interaction shows that when the mother's depression is remitted, the characteristics of play with the mother is still less joyful. And Cooper and Murray did a study which showed as well that treating the depression did not lead to an improvement in the interaction once it was set. So these are two contradictory studies. And here is my one mention of fathers for Janet, if she's still here. But Field showed in '88, looking at 3 to 6 month old infants of depressed mothers, that when they were watched with another adult, not their mother, that they also showed what they call the depressive style of interaction. However, contradicted by Hussein in '94, looking same age children, and they looked at the interaction of the infant with their non-depressed father and showed that there was a differential, the depressed behavior towards the depressed mother, but not to their non-depressed father. So Ashley has referred to some of this long-term impact on the child. Moving quickly through, we all know about attachment theory and the importance of a secure attachment which allows the child to develop a sense of himself as being worthy of care and protection, and a view of the other, primary caretaker, as being reliable. In our research study, the attachment scale that we used categorized 4 types of four attachment styles in adults. This is a little bit different than the categorization that Ellen Most used when she was here. And we know that adult attachment style is a risk factor for perinatal depression, insecure attachment increasing your risk. We also know that perinatal depression increases the risk for insecure attachment in the baby, and particularly the chronicity of the maternal depression. However, depressed women who are able to maintain a good, sensitive interaction with their baby, despite the presence of their depression, are less at risk of having an insecurely attached child. And we know that depressed women who themselves have a secure attachment style are less at risk of having an insecurely attached infant. So I want to move on a bit towards the research component of this talk. First of all, to tell you about our perinatal mental health service. It's a consultation and treatment service here in the psychiatry department for pregnant and postpartum women. And we're now seeing somewhere between 125 and 150 women a year. And we get referrals from within the JGH system. Give you an example, a clinical vignette of a woman that came fairly recently, and she represents sort of a typical woman presenting to my clinic. So she's a 26-year-old woman referred from the breastfeeding clinic here at the JGH, 2 months postpartum for evaluation of depression. And she had no prior history of anxiety or depression, but described herself as always having been sensitive. She'd gone to the breastfeeding clinic because of concerns that her baby wasn't getting enough milk and wasn't growing appropriately. And she felt tremendously burdened by the expectation of having to breastfeed. She stated she had barely enough energy to take care of herself, and the constant demands of her infant crying and feeding every 2 to 3 hours was more than she could bear. She admitted that when she was alone at home with the baby, sometimes she wouldn't respond when the baby would cry and just leave the baby in a room by herself. She felt terribly guilty about this and knew that her husband would be upset because he believed very strongly that they should respond immediately to the baby's cries. She stated that she and her husband were arguing about this and also about breastfeeding. She wanted to give up, and he insisted that she continue to nurse. She didn't think that he understood how hard it was for her. So she brought the baby to the first evaluation in a stroller. And at one point, the baby began to fuss, and she tried to rock the carriage back and forth to settle the baby, but then wasn't able to, and the baby was escalating. So she took the baby out of the stroller and held the baby in her arms, but noticeably away from her body, and had what I call to myself the sack of potatoes sign, where the baby was lying across her arm with the head kind of hanging over the edge of her arm. And for those of you who've been in my office, I have these chairs that have these horrible wooden arms on them. And the head, I was getting nervous watching this baby's head just sort of hanging unprotected on the wooden arm. And she continued to speak. Speak over the baby's cries, over the baby's reaction, just to speak about her distress. At one point, she wasn't able to settle the baby, so she took the baby and said, "Do you mind if I breastfeed?" And I said, "Of course not, because I want to watch and see what's happening." And she put the baby on one breast, and just as the baby was beginning to find the nipple and beginning to latch, she took the baby off and switched the baby to the other side, and then the baby would get more fussy again. And she took the baby off and put the baby over her shoulder in these jerky movements. And you know how people pat the baby on the back? This was a rough pat. And at no point in this did she speak to the baby or did she look the baby in the eye. It's really horrifying. And unfortunately, this story is fairly typical of some of the mothers that I see, women who are so burdened by the breastfeeding. She was clearly unable to soothe herself and unable to soothe the baby. So that's an example of the kind of women that come and see us. And as Phyllis mentioned, I'm part of this large study, Maternal Mood and Oxytocin, and we recruited women from a community sample here at the obstetrical clinics, from the Maison de Naissance, the birthing center down the street, and also from my clinic, and we recruited 75 women from the perinatal mental health service. So this is just some of the data from the women from my clinic. We recruited 39 women prenatally. There were 9 dropouts, so the final sample size was 30. And of these, a little more than half were diagnosed with a mood disorder. Bulk of the rest were diagnosed with an anxiety disorder, but we also had some with pure couple conflict, psychotic disorder, various other diagnoses. And we had 36 women recruited postpartum. Again, 6 dropped out, so we were left with a sample size of 30. And these are women that are referred anywhere from delivery to 6 months postpartum is my definition of catchment. The demographics, the mean age was very similar, as was marital status and common law. We had slightly more women in the postpartum sample that were in their first pregnancy than those who were recruited in the prenatal sample. This may be actually a result of the OBGYNs and the nurses in the perinatal unit increasingly picking up women who have had a previous bad experience after delivery and referring them during their subsequent pregnancy, something which I really appreciate. So we looked at intake. We had a clinical diagnosis at intake. We had a variety of measures that were used. These are just some of them, including the adult attachment rating. EPDS is a Edinburgh Postnatal Depression Scale. This is a very simple 10-item self-report screening tool for depression in pregnancy or postpartum period. And the women were seen and assessed at the point of entry into the trial. If they were pregnant, into the study, if they were pregnant, they were assessed then. If they were postpartum, they were assessed at that point. And then every woman had a home visit. The pregnant sample had their home visit at 8 weeks postpartum. If they were recruited postpartum, they had their home visit as soon as possible after the point of recruitment. And at that point, a mother-infant interaction was done using the global rating scale. And the setup for that is very similar to the video I showed you first, where you have the mother and an infant in her infant seat interacting, and you can watch simultaneously the mother's face and the baby's face. The depression score at recruitment, there was no significant difference between the 2 samples, the pregnant or the postpartum sample. By the time we look to when you follow the prenatal sample through to their postpartum period, the depression score has come down significantly. 12 is the cutoff of significance, so hopefully this represents a treatment effect, that the women who are coming during pregnancy are actually better by the time they deliver. And the postpartum sample, there's less of a difference between recruitment and home visit. It occurs shortly after they're recruited. We matched my clinical sample with a community sample taken from the women recruited through the general OBGYN clinics here at the Jewish, and we matched them for parity, education, marital status, and age. And this is really the one slide which shows the findings. So the clinical sample was significantly different than the community sample on maternal sensitivity, intrusive behavior, and depression. Depression we would expect. Bear in mind that the way that this interaction is rated is high scores are good. So when you look at maternal sensitivity here, the clinical sample is significantly less sensitive than the community sample. Similarly, with intrusive behavior, high scores are good, so clinical sample is significantly more intrusive than community sample. Intrusive behavior refers to the mother's physical behavior with her baby and includes things like poking, prodding the baby, snapping fingers in the baby's face, things that are intrusive in the physical space of the baby. of interest, I think, is a difference in the breastfeeding status at 8 weeks, which refers back to my clinical vignette. The clinical sample, only 75% was still breastfeeding by the 8-week postpartum visit, compared to in the community sample, we're close to 90%. So I've definitely seen this, that I feel that a lot of my women have significant difficulty breastfeeding and are therefore more likely to stop prematurely. So in terms of the implications of this, I mean, for me, this has been a wonderful experience. After 20 years of working clinically with these women, evaluating them, treating them, it's been really wonderful to work with a research team and add that to my practice. And specifically using the, I've introduced multiple questionnaires into my clinical practice as screening tools, which I really enjoy. And I'd like to make a point for having gone through the process of learning about the global rating scale of maternal-infant interaction. It certainly helps you to think about what you're observing between the mother and the baby in a much more rigorous way than just simply observing. That's it.